we go to the last speaker, and the last speaker will be online, or at least recorded, I think. And that is a subject called Pain in Pompe disease by Heidi Peters. And she is the clinical head of the Department of Metabolic Medicine at the Royal Children's Hospital in Melbourne, Australia.
Well, thank you for inviting me to present it at the Pompe meeting. I'm going to talk about pain in Pompe disease. And so my name is Heidi Peters, and I'm a metabolic physician who works in paediatric metabolic management, and I work in Victoria in Melbourne in Australia. And this is a picture of the hospital that I work at and within Melbourne. I'm sorry I couldn't be there in person, but I hope this is okay. So pain is an important topic, and is one that doesn't really necessarily attract a lot of attention in the literature in Pompe disease. But it's important because the management and the management of pain has an impact on a person's well-being and daily functioning, and if present can have a significant negative impact on daily life. So according to the International Association of the Study of Pain, the definition of pain is one of an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So I think the thing that's important here is the multiple components. In particular, it's a sensory and also an emotional experience. And it may not be directly proportional to the amount of tissue injury. So it's a very subjective and entirely individual personal experience, and it's influenced by a whole lot of factors, including by previous learning around pain, its context, and multiple psychosocial variables as well. And it can be classified into a number of different groups. It can be classified as acute pain or chronic pain, or a combination of both. So chronic pain is defined as pain that persists beyond the normal time of tissue healing, and it's deemed chronic when it's more than 3 months in duration. It can also be classified in a physiological sense. So pain is a process where you have nociceptive receptors, and you can have in your tissues and your visceral organs, and they detect the sensation. And that's known as nociceptive pain. You have neuropathic pain, and a more recent terminology is nocioplastic pain, which seems to replace what was previously known as centralized or central pain. And so when you have a noxious stimulus, your nociceptors detect it and send a signal to through your peripheral nerves to your dorsal root ganglion along your spinal cord. And then the message goes in the ascending pathway up to the brain, and your brain will then process that and modulate it, and there will be descending pathways inhibitory that inhibit the pain as well. So nociception itself is not the same as pain, because there are many other things that will impact on the signal, and then the pain is what you actually feel and what must be treated. So I guess that what's important is what's then that message that's in the brain, and it's the brain's perception can be impacted by the context. So the pain beliefs, placebo expectations, a cognitive set. So there's the thought that the catastrophizing mindset or distraction or things like that can impact your perception of pain. The chemical structure of the brain and mood. So depression, anxiety, sleeplessness can also impact how you feel that pain. And then there's the modulation of that pain and in the descending pathways, and they send signals to the periphery to modulate the pain. So it's a complex interactive process. So nociceptive pain is usually that which you feel, which is tissue injury, or if there's a cut or something sharp, it's usually a sharp, dull, well-localized pain, and is less likely to be a feature in Pompe disease. Neuropathic pain is caused if there's a lesion or a damage to the nervous system, so anywhere in that pathway. And it's often described as shooting or pins and needles or numbness, and it's not well localized. And then you have the nociceptive pain, which you can think of as things such as irritable bowel syndrome or fibromyalgia or tension headaches. And acute pain can, if it's persistent, can progress on to a chronic situation. So you've got a sensitization of the and a chronic dysfunction of the nervous system with excess sort of a firing and a sensitization. And so then that can lead on to a situation of chronic pain, so where you may have hyperexcitability or a change in the inhibition pathways. And that causes an imbalance and the onset of the chronic pain. So the fundamental principles for pain management are that pain is an experience that cannot be separated from the patient's mental state, environmental, cultural background. It's complex and it needs a proper assessment to determine the cause and the triggers. The assessment of the pain and documentation of the effectiveness of any interventions are fundamental to successful pain management. And when you're thinking about pain management, both non-pharmacological and pharmacological treatments can be used to minimize the experience of the pain. And it's also very difficult to actually measure and compare and quantify pain because there's no real physical imaging or behavioral or lab tests that can identify or measure pain, and it's a very individual experience. There are a number of tools that have been developed that have tried to look at all these aspects of pain, but there's a lot of variability across them. So when we think about treatment, it's important to think about a multimodal treatment. So this can be and usually not just one, but a combination of all of these aspects. So it may be a pharmacological therapy, so medications or drugs, interventional approaches such as injections or neurostimulation, psychological support, lifestyle changes, complementary alternative treatments, or physical or rehab. And all of these interact to help try and modify the pain and improve functioning and well-being. So if we think about Pompe disease specifically, there's actually limited data in the literature about pain in Pompe disease, where that is the main focus. And if you do a Medline search, there's only about 5 reported specific reports on pain in Pompe disease. And I guess that's because pain is not really a cardinal feature of the condition, unlike in some lysosomal storage disorders, such as in Fabry disease, where there's a very pathognomonic description of pain. And a focus of management in Pompe disease, I think, has really been around management of a lot of the other aspects of the condition, such as muscle strength and respiratory function, and not so much on these areas such as pain. But nevertheless, there's a large number of individuals with Pompe disease who report experiencing pain. And this has an important impact on an individual's quality of life and well-being. So reports of pain were initially reported as single items on questionnaires, and those questionnaires were not mainly focused on pain, but focused on other aspects, and this was drawn out from those questionnaires. And really the largest study was undertaken by Günger et al. And reported as a large cross-sectional study examining pain specifically in 124 adult late-onset Pompe disease patients, and compared to 111 controls. And this was in a Dutch and German population. And what they examined was the prevalence of pain, the severity, and the pain characteristics in late-onset Pompe disease. And it was examining pain experience in the previous 24 hours. In addition, they also looked at the quality of life, participation, anxiety, and depression. And they used a brief pain inventory, a short form health survey, hospital anxiety and depression scales, and the Rotterdam handicap scale to assess the pain. They had a 60% response rate, which was reasonable. And they identified that pain was present in 45% of the patients, or 45% of Pompe patients, and had a severity score of 3.1, so that it was a mild to moderate pain, and that pain had a mild interference with daily activities, in particular with walking and normal work. And this and it was related with a reduced quality of life, less participation in daily life, and a greater anxiety and depression. And this was scales they showed, the top one being the percentage and the pain site. On the left is Pompe patients, on the right are controls, and you can see there is a real, the main site of pain was reported in the back, upper legs, thighs, as opposed to in the controls where it was quite variable. And the pain was described at the bottom. The diagram shows the description of the pain, and it was evident that in Pompe population, the pain was really described as exhausting and pulling, tearing, or a dull pressing pain, which is again a different distribution to what is seen in the controls. And more than 70% of those who experienced pain were using treatments for it. And these mainly consisted of simple analgesics. Some had used physical therapy and some used a combination of both. But it really was probably suboptimal in terms of the management of that pain. Carabul et al. Then subsequently went on to look at a cohort of 25 UK late onset Pompe disease patients, and they looked at the experience of pain over the previous 7 days. And they showed that there was actually 88% of patients reported pain. They had a similar severity of pain and inhibitory pattern and distribution as that was described by Gunger et al. And they concluded that the present data suggests that in addition to a large proportion of patients having current pain, an even larger group suffer from pain in daily life. And so this emphasizes the importance of pain in the long-term treatment of patients with Pompe disease. Then Tucker and Bartley have undertook a review of pain in different groups of rare neuromuscular and musculoskeletal disorders, including Pompe disease. And they examined different mechanisms and suggested there's also a role played in pain generation from glycogen deposition within the central nervous system, including the peripheral and central nervous system. And they said that it was supported by the hearing loss, small fiber neuropathy, cognitive functioning, and MRI changes. There has also been a report by Hobson and Webb about small fiber neuropathy in a group of Pompe patients they examined, where there was reports of paresthesia, burning, and tingling pain. And it was questioned whether this may be another mechanism for pain in Pompe disease. Contradictory to that, Enax and Kremova et al. Looked further at 35 late onset Pompe disease patients to look at small nerve fiber involvement and a pain questionnaire, and they did a skin biopsy to look at the small nerve fiber pathology. In their study, they identified that pain was a common symptom, in a similar frequency to the previous studies. There was also a reduced nerve fiber density in a large number of patients. So in this diagram on the right, you can see the patients and where their pain was and who described pain. Those with the small red boxes were those that had reduced nerve fiber density. However, there was only one patient who had neuropathic pain in this group, despite having reduced nerve density. And they concluded that the pain characteristics and distribution were not consistent with small fiber neuropathy or neuropathic pain. So I guess this highlights the importance of really understanding the mechanisms of pain to try and in determining the treatment modalities. So Tucker and Bartley also highlighted the role of the skeletal system in pain. In particular, the presence of lordosis and scoliosis and shifting of the spine can limit mobility and fatigue, and this can worsen the pain. And also compounding factors such as skeletal pathology, psychological pathology, problems with respiratory system, contractures, osteopenia, or lack of sleep, or or disordered sleep can all compound the experience of pain. So it's really a multi-system disease with many compounding factors, and it's not static, but a situation that is changing. So they describe the types of pains as being related to arthralgias, myalgias, back pain, bone pain, and neuropathic pain, along with inflammatory as well. So if we then turn to look at ways of managing this, one possibility is the pharmacological approaches. So enzyme replacement therapy, whilst important in the management of Pompe disease, there's no clear evidence that pain improves post an infusion. So its role probably is more in a longer term preventative management of the condition with hopefully prevention of pain. Simple analgesias have a role, but may be suboptimal in controlling the pain on their own. Opioids probably are not recommended, particularly for long-term chronic pain due to their side effects and possible detrimental sequelae for Pompe patients, in particular effects on the respiratory system. And medications for nerve pain, such as gabapentin, tricyclic antidepressants, carbamazepine, because there isn't a clear role of neuropathic pain in Pompe disease, it may not be appropriate to use. Other approaches include interventional methods, and this includes things such as nerve root block or musculoskeletal injections. And there's one report in the literature of one individual who had chronic lower back pain, who had 2 steroid and local anesthetic nerve blocks, which resulted in temporary relief of pain, but there was reluctance to go on and perform radiofrequency ablation, which would give a longer term improvement potentially, due to concerns about weakening the muscles, the paraspinal muscles, and causing worsening stability. And then there's, I think, really one of the main approaches that need to be considered as the non-pharmacological management. And there's a lovely study by Fabergé et al. Looking at effects of pain and fatigue and functioning after undertaking an exercise training program. So this was a 12-week exercise program looking at improving aerobic resistance and core stability. It was trained and supervised by physiotherapists in 25 mild late onset Pompe disease patients, and they concluded that there was a significant improvement in the levels of fatigue and the levels of pain in these individuals, and it was not associated specifically with aerobic fitness or muscle strength. So pain services are really important in the management of pain, and many of the many centres now are integrating pain services into their services, and this provides a multi-pronged approach to the management of chronic pain. And this is based on the premise that pain is related to a complex interaction of biological, psychological, and social factors. And this holistic approach would involve the potential involvement of a physician, nurse, a clinical psychologist, particularly looking at cognitive behavioural therapy skills, stress management techniques, education about issues impacting on the psychosocial well-being, pain beliefs, and social functioning. A physiotherapist also has a role in improving fitness and guiding pacing, use of aids, help addressing feared or avoided activities. And then other modalities such as traditional medicine, massage, hydrotherapy could be considered. So really the best treatment is the combination of pharmacological and non-pharmacological strategies. And pain is a complex response requiring proper assessment and management. It really, the patient as a holistic preferences and mechanisms need to be considered in determining what's the best approach to treatment for that individual. And that may require a pain specialist to be involved as well. So in relation to pain and Pompe disease, it's evident that pain is a frequent occurrence. The cause can be multifactorial and change over time. It impacts the well-being and as such should be an important consideration in the overall care of patients with Pompe disease. Further studies are really needed to determine the exact pathophysiology and hence design the best management. And also the longitudinal aspects of pain in Pompe in relationship to the disease stage need to be examined. And a more standardized set of tools to try and assess and compare the outcomes of pain and pain management should be considered. So thank you for listening to me, and thanks very much.